Jurassic Region, and 45.
We just go with this one then. This is still number one.
Flip it back. Or no, you. This is number one. This is where we are.
Still number one. This could be number two still.
And 2. And then 3. And then 4 is Brandy Mize.
So this is the Emory group. You know what Kristen is? She's a surgical resident.
She's a 4th-year resident.
Fellow.
And she's a 4th-year resident. And her name is pronounced Bacher. You want me to introduce her?
Then I'll introduce Kay and go with the next one. Then this one is apparently nice. That's easy.
Just ask her if we should get started.
I think, Randy, you want us to push forward? I think this is it. Walk over there and ask him if that's the projector to go forward and backwards.
Okay. All right.
What's that? Yeah.
Settle issues with the kid.
I did. I got everything arranged so that he has all our bags. And he's 17 now. So I'm like, look, here's money for the mailman. Do this, get the truck ready. You
Why
know,
don't you just ask for the. I say just pop them up all at the beginning. Okay. What do you say? Do we use him or don't use him or questions?
the pull.
Yeah.
Yeah. I think having a pull up there of how many people do thoracic endographs. I think that's a great idea. Yes.
Okay. So then we just go one after the other. Just whatever. Thanks. Doing okay? Awesome.
I'd like.
Leave the podium.
Okay, so I'll just press.
Yeah, green button will take you.
They're out there. That's right. Was that Cajun man moderation?
Didn't know you guys were. Something just come and check my guys.
Yeah, good. Thank you. It's yes. And that's, we don't, and we shouldn't. Yeah.
It's 2 years. We made 625.
That's fantastic.
It's going to go say I don't know.
That's great. That's wonderful. Makes me wonder what I'm still doing there. Like, you know. Is this working yet? I'd like to invite everyone to get a seat so that we can start this session. Before we start, I'd just like to extend a sincere thank you to the invited speakers from this morning, because as someone who's been dealing with burnout for the first time in my career from a variety of issues, I got a little breath of fresh air from everybody's perspective. And I really appreciate the reframing and the meetings. This meeting, I've always often found a source of inspiration in each of these meetings. And thank you for providing that this morning. They were wonderful talks and wonderful messages, and thank you. As an introduction, I'm Jonathan Molnar. I'm from Rome, Georgia. I'm a vascular surgeon.
Juan Ayerdi, I'm a vascular surgeon in Columbus, Georgia.
And we are going to be moderating this session, and we have the resident session. And our first speaker is going to be Dr. Kirsten Bacher. She is going to tell us about the thoracic branch endoprosthesis experience at Emory University.
Good morning, everybody. My name, as I said, is Kirsten Bacher. I'm a PGY4 general surgery resident at Emory, and today I'll be presenting our experience at Emory with the Gore thoracic branch endoprosthesis since the FDA approval of this device. So as we've heard mentioned in many talks, the endovascular techniques are ubiquitous in terms of management for descending aortic pathology, both due to improved perioperative and short-term morbidity and mortality, as well as the ability to avoid an open operation. However, aneurysms frequently have a proximal extent within 2 centimeters of the left subclavian, precluding a standard TEVAR unless you're accounting for the occlusion of that subclavian. And so the current accepted approaches for managing the revascularization are carotid subclavian bypass or a left subclavian transposition. Left subclavian revascularization has made TEVAR less prone to complications than prior, particularly with respect to stroke and spinal cord ischemia. However, there are still significant risks and logistical issues to be considered when adding in a second surgery. These procedures obviously require an open operation in the neck, which introduces the complications inherent to a neck operation, as well as adding an additional procedure that needs to be done either in a staged fashion or preoperatively before starting with your TEVAR, which just adds, time and creates a bit of a slog for that day. So additional strategies for managing these aneurysms or aortic pathology that are not amenable to a standard TEVAR includes creation of physician-modified fenestrated or custom grafts for this area. But the lack of standardization with these devices makes them, 1, difficult to study, and 2, difficult to introduce across institutions and practice locations. And so enter the first FDA-approved device in the United States for this scenario, which is the Gore thoracic branch endoprosthesis. It was approved in May of 2022 for patients with appropriate anatomy who are at high surgical risk for operations in the neck. Initial studies of this device are promising. I won't go through this exhaustively, but 1, 2, and 3-year follow-up have demonstrated excellent technical success rates with low rates of stroke and spinal cord ischemia and good graft patency at 1 and 3-year follow-up time points. There have been a reasonable number of endo leaks observed with this device, about 30% at 1 year in the initial feasibility study, which I'll touch on again later. The TBE device is currently, oh, I can't make this play. Okay. Well, the TBE device is currently approved for aortic pathologies in the zone 2 aorta. So like all endovascular devices, there are some anatomical limitations which preclude the device from use in certain patients. But for successful deployment, patients must have adequate access as well as appropriate landing zones in the proximal and distal aorta, as well as in the distal left subclavian. And simply, as would be shown in this video, the steps to deploying the device include obtaining wire access to the arch via femoral approach, and then access to the target vessel via brachial access, and then deployment of the aortic component of the graft over the femoral wire, followed by deployment of the branch device over the upper extremity wire and subsequent balloon angioplasty. And although we had previously used this device in select patients since about 2017, since commercialization and FDA approval, we've used this device in 9 patients across the Emory campuses between October of 2022 and February of 2023, who are the subjects of this series. And the average age of these patients was 64 years old. 44% of the patients were male. The primary indication for use of this device was for a dissection, although closely followed by aneurysms and penetrating aortic ulcers. Little over half of the patients, 56%, had a concomitant procedure at the same time, such as a TEVAR. 33%, about a third of the patients had previously operated on aortic arch, and 2 of them actually had bovine arch anatomy. And in terms of our outcomes, 44%, so just under half, did have some sort of complication. We had actually 0 events of stroke or spinal cord ischemia in terms of our cohort. We did have 1 suspected rupture and then 3 radiographically documented endoleaks. At the time I collected this data, 1 patient had undergone an emergent open arch debranching and extension of the proximal TEVAR. And then 1 had an additional open arch planned for and type 1A endoleak. And then 2 patients, 1 patient was planned for a repeat TEVAR for an endoleak, and 1 patient was planned. She had not had an endoleak or complication, but she was planned for a 2nd stage FEVAR. And actually I saw her in the emergency department like a week ago, unrelated to this procedure, but she decided to stop taking her Eliquis and came in with a PE. And the duration of follow-up, was, there was 1 patient who was deceased at the time of data collection, and the remaining 8 patients were alive. The duration of follow-up median was 53 days. So briefly, I'll attempt, if the videos let me, demonstrate an example of one of our cases. So the patient's history here is listed on the slide. She had been followed by vascular and cardiothoracic surgery for a finding of an 11 by 7 millimeter penetrating aortic ulcer, which was incidentally identified on scan in 2021. And at that time, monitoring with serial CTs was recommended. But in early 2023, she developed worsening chest pain now associated with shoulder pain, and the recommendation in the absence of any other etiologies for her pain was made to proceed with endovascular repair of the ulcer with a TBE device. And so here's a representative image from her preoperative scan, which demonstrates the disease segment of the aorta. This is just a different slice that shows the takeoff of the left subclavian. So you can see that they're close together. And now this overlays just a measurement demonstrating that it is well within 2 centimeters, precluding a standard TEVAR. So we'll see if this works. So this first shot just demonstrates the placement of the wires with the endograft already in place over these 2 wires. This is the arch angiogram, which is not going to play, sounds like, but it demonstrates that the device is set up to be deployed in the appropriate position. It's not overlaying or occluding the origins of the more proximal great vessels. The next shot demonstrates, well, it would demonstrate appropriate deployment of the aortic component of the endograft. Next, the side branch here you can see is deployed in the left subclavian. And then the graphs were balloon angioplasty, and the completion angiogram does demonstrate maintained flow through the left subclavian artery without opacification of the disease segment of the artery, of the aorta. And at last follow-up with vascular, this patient was reporting improvement in her chest and shoulder pain. And her most recent follow-up in the system, not with vascular, was with her primary care provider. She was 7 months post-procedure, and she was doing well. She had not suffered any complications. And so in conclusion, thoracic barge endoprosthesis is a reasonable approach for thoracic aorta pathology involving zone 2, with encouraging outcomes in the literature and in our institution. The most common complication is endoleak, which in our small series is slightly higher than in other published series. We did have 1 mortality that was related to endoleak or suspected endoleak and rupture, which reinforces the need to continue to fully study our patients and their outcomes to learn from these types of events and hopefully prevent them from happening in the future. And encouragingly, we did have a 0% stroke and paraplegia rate in our cohort. And so that's all I have. Thank you for your time, and I'm happy to take any questions.
One question I have is, this is a high-level presentation of thoracic branch devices. we in the community are not going to be doing these cases,
Yep.
but what how essential is IVUS? Is it imperative? Is it useful? How do you find IVUS in deploying these?
So my personal experience with this is extraordinarily limited, but I would say that it is, especially when using for dissection, et cetera, it's exceptionally useful to use the IVUS.
I love IVUS. My techs call me the IVUS king because I think we run out of IVUS catheters just about every week. In general, I would tell you that you actually don't need a lot of adjunctive imaging for this. Dissections, for sure. Use IVUS, make sure the right lumens. Because you have a wire coming out from the left subclavian, though, you can see everything even with just fluoroscopy. You don't need to shoot a bunch of angiograms to deploy this. I will say having a friendly cardiac surgeon is very useful because you don't get as much extra coverage as you think. Even though you're covering the left subclavian, you may want a friendly cardiac surgeon to do an arch D branch for you for the innominate and carotid. Bovine arch patients, excellent for these. They got a ton of space between the innominate and the left subclavian. They're a perfect population to use this device. But as soon as you start treating disease in the arch, there's a lot more complications. They are sicker patients. The disease is just, it's worse. That's a little more than just IVUS, but.
So those are very encouraging results, especially the spinal cord ischemia. You know, do you have any data as to what the extent of coverage was on the initial procedure?
I did not examine that. That would be a relatively easy thing to go back and look at. It's not an extensive cohort. I also think it'd be valuable to extend both the follow-up. It's now, what is it? It's September. And I collected this data in February. So I think that would be one thing to add on. And to look at further case related details.
Very good. Thank you.
Yeah, in terms of the result of our medication,
Mhm.
60 days, we convert
Mhm. Mhm.
If you look at which patients were outside by.
So my understanding, and Dr. Chang, you can correct me if I'm wrong, is that all of these patients were within IFU? No, okay.
If one person said about the patient that followed, she did beautifully discharge and post-CAT scan was very through nicely. There's no retrograde section. Now, a week later comes in with left thorax with one. Assuming type 1, the doctor doing the cardiac surgeon, doing the plasma branch, for the piece, the angiogram stuff, there's no reason. Unfortunately, the patient arrested very we have a pretty good back, and so we inspired from that. I think for sure very similar problems.
Can I add to that answer, William, that I think that the point is these results probably, I think initially I would expect the results are not going to be as clean as a clinical trial because anytime I think when new technology goes through a strict regulatory environment, the patient selection is very tight. And once we gain experience with it, we start to apply it outside in other areas. I also believe that that doesn't mean we should throw the technology out. Just expect sometimes you're going to see some hiccups. And I think that happens anytime you bring new technology, a new technique. Once you gain a little bit of experience, you start to get a little bit more brave and push it. And that's where you run into higher comps. I do think I would expect it to bump up a little bit when it gets out. Jerry?
Thank you. You're really training at a great place. I'm going to read ahead. And it's really good that the bosses are here because they're going to answer this question, not you. But first, technically, how do you deliver the stent? Do you go transbrachially and then deliver it retrograde femorally, or does it go transbrachially? And secondly, what's the size of the fenestration? Because obviously I'm thinking about the innominate debranching and or laser fenestration.
I can.
And that's not an IFU question, obviously.
So the stent's typically delivered from the femoral. Because you already got a giant sheath in there. So from the brachial axis, you really only need a 5 or 6 French sheath to be through that. There are some folks, I don't know, I know some folks doing transradial access for it too, because you're really just doing it for wire stability. So how much do you actually need the brachial access? We'll see as the experience continues. The portals come in 2 sizes, 8s and 12s. The 8mm portal is about 2 centimeters from the back end of the portal to the front of the graft. So that includes the subclavian in that coverage when they're measuring it. The 12mm portals were in the trial, they were for zone 0s. And so they're about 4 centimeters from the back of the portal to the front of the graft. So you get a lot more coverage with the 12. And that has been my preference moving forward with it is let's not have a proximal seal zone problem. Let's put the 12 in if we can do it. Again, the friendly cardiac surgeon does help those things.
Thank you very much.
Our next presenter is Dr. Kay Bierster, and she's going to talk to us about the treatment of aortic coarctation.
Good morning. My name is Kay Bierster. I'm a PGY2 general surgery resident at the University of Tennessee, Chattanooga. Thank you to the Georgia Vascular Society for allowing me the time to present this case today. I will be presenting a case of endovascular rescue of iatrogenic aortic coarctation following a hemiarch replacement with TVAR for type A dissection. Thank you. We have no disclosures. Our patient is a 59-year-old female with no known past medical history who initially presented with a Stanford type A dissection. The dissection began distally to the coronary ostium, involved all of the great vessels, and extended into the external iliac arteries bilaterally. She was taken emergently to the operating room with the cardiovascular surgery team, where she underwent a valve-sparing zone 0 hemiarch repair. Per the operative report, a TVAR device was deployed in an antegrade fashion distal to the left subclavian artery in an attempt to expand the true lumen. Postoperatively, the patient exhibited failure to thrive and was admitted twice from rehab with congestive heart failure, claudication, and acute renal failure. She required multiple thoracenteses and tube thoracostomies for volume overload. During this time, she also developed a stage 4 decutaneous ulcer. 6 weeks post-intervention, CTA demonstrated residual dissection within the arch and great vessels, as well as malpositioning of the proximal portion of the TVAR along the greater curve of the aorta. There was significant stenosis of the proximal lumen of the TVAR, as seen by the bird's beak appearance here. Given the patient's deconditioned state and concern for coarctation physiology, our team was consulted. At this time, 2 general operative strategies were considered. Number 1, redo open sternotomy and arch replacement with a frozen elephant trunk, as this would address the stenosis and treat the residual arch dissection. Or number 2, a less invasive endovascular relining and TVAR extension with intentional coverage of the left subclavian artery in an effort to position the graft out of the curve of the descending thoracic aorta and to allow safer proximal balloon expansion of the stenotic areas. This approach would not address all of the residual arch dissection. However, patient factors had to be considered. At the time of planned intervention, the patient was requiring 7 liters high flow nasal cannula, could not ambulate without claudication, and had a serum creatinine of 3. Given the patient's significant deconditioned state and non-aneurysmal arch, the endovascular intervention was recommended. Furthermore, this option did not preclude future open or endovascular arch interventions. Pre-treatment IVUS showed a minimal luminal diameter of 3.7 millimeters. Initial attempts to traverse the stenosis with our TVAR device were unsuccessful. Therefore, a 10 millimeter balloon was inflated via the contralateral access at the level of the stenosis. As the balloon was deflated, a Cook 32 millimeter by 155 millimeter TVAR device was advanced concurrently into position. Covering the left subclavian allowed for adequate proximal extension to effectively balloon the stenotic areas and provide enough purchase of tissue to oppose the device to the aortic wall. After TVAR deployment and ballooning, IVUS demonstrated luminal diameters of greater than 20 millimeters throughout. The patient awoke from anesthesia with no neurologic deficits. Her serum creatinine returned to normal, and she was weaned to room air in less than 96 hours. She also experienced resolution of her claudication. 6 months postoperatively, the patient was doing well overall. Her renal function remained within normal limits. She denied claudication, and she's nearly completely healed her decubitus ulcer. Repeat CTA demonstrated widely patent true lumen throughout the TVAR stents. Notably, the untreated segment of the aortic arch continued to have residual dissection, but was without significant growth. She was noted to have thrombosed the majority of the false lumen, though retrograde filling of the false lumen was seen from the left subclavian artery. In an effort to promote further thrombosis of the false lumen and favorable remodeling, we returned to the endovascular OR for embolization of the proximal left subclavian artery. We will continue our longitudinal follow-up with a repeat CTA in 1 month to assess the residual dissection. Should the patient demonstrate aneurysmal degeneration or require intervention to address the untreated aortic dissection of the arch, both open and endovascular definitive repair options exist. Among those are a redo sternotomy with debranching of the innominate and left carotid while sewing to the TVAR distally, or a right to left carotid bypass, plus or minus a left carotid artery to left subclavian artery bypass with a zone 0 thoracic branch endoprosthesis landing in the hemiarch graft. This hybrid approach, again, avoids a redo sternotomy and offers a less invasive approach. With the role of endovascular surgery rapidly expanding for complex aortic pathology, it is important to consider device limitations, anatomic considerations, and patient factors to better guide the choice of surgical therapy. We present a rare case of post-TVAR coarctation. The initial TVAR failure underscores the need for proximal fixation within non-dissected aorta or graft. However, patient factors may supersede this dictum, as in this case, where prohibitive medical comorbidities prevented open definitive repair. This patient was safely and successfully treated with endovascular therapy. Our TVAR placement, although landing in dissected aorta, provided clinical and symptomatic relief of the patient's coarctation physiology. We were also still allowing future definitive management if needed. This case highlights the complex nature of vascular surgery and demonstrates the expanding and meaningful role of endovascular technology as a complement to traditional open vascular surgery techniques. Thank you for your time, and thank you to my mentor, Dr. Staten, for allowing me to be a part of this case. I'm happy to answer any questions.
So we're open for questions, but clearly it seems that in most settings, from what I have seen, most of my cardiac surgeons these days prefer to do a hemiarch replacement from the get-go. And in the few instances that I've been asked to help expand this proximal portion of the endograft, we call this a frozen elephant trunk, I believe. And we usually put some tacking stitches so there's no migration of the device. So this is potentially something that can be prevented from the onset. Dr. Jordan?
Congratulations on the presentation, and I really want to congratulate you on your bravery for presenting the case. I would take one argument that it's not so rare. I think you've just been one of the ones brave enough to put it up on the screen for us to talk about it. Two questions. What was done in the early post-operative period to evaluate the assessment of the endograft, chest X-ray, non-con CT scan, to really sort out how much it was, quote, migration versus mal-deployment, maybe? In the old vernacular, we would call that the jerk on the end of the string, if you know what I mean. So I would be interested to know, again, taken from the book of Dr. Baldrige of Look, Listen, and Feel, because you probably could have evaluated this on a pulse exam or even an ABI to see if there was a difference. So what was done?
Thank you for your question. I believe that her first imaging study was a CTA at 6 weeks post-operative from the initial operation. Of course, these patients with type A dissections have very high morbidity and mortality following the index operation. I think that initially it was assumed that she was recovering from an open sternotomy and just had trouble recovering since she did have 2 readmissions from rehab. And it wasn't until later that our team was consulted after the CTA was done that saw the coarctation.
Dr. Pugh.
Well, these are tough cases, and I actually think your closing comment is correct, is we probably need to be more involved in these things nowadays. You gotta be careful what you wish for, because they seem to happen at inconvenient times. I think the biggest issue is we have several great cardiac surgeons. They all do ascending type A dissection repair a little bit differently, but they all say they do a hemiarch. And when you look at the scans, some people really do a hemiarch with a frozen elephant trunk. And the ones who I've seen that have been very successful, they actually bevel their graft and then they anchor the stent graft to their ascending Dacron graft, at least partially. There, I was showing Middleton, the Emory website actually is a great picture of it. But that looked to me like it was a total ascending, it was just an ascending repair interposition graft. You can see the pledgets circumferentially around the origin of the innominate on your, that go back, yeah, right there. That, I think, no, not the proximal, I'm talking about right in front of the innominate. You can see they just, that's their distal anastomosis. Looks to me like it's right in front of the innominate. They just did an ascending interposition graft. They cut a bunch of the septum out and shoved the stent graft in and said they did a hemi. And again, that's not uncommon. I've seen that frequently. A true hemi arch, you have to bevel under the arch, take out the flap, and you're really looking at the descending thoracic aorta. And I think that's probably what happened here. I mean, this is not M&M. We're not pointing fingers. My point being is I just wanted to reinforce that just like we all do certain things probably a little bit differently and then just dictate it as juxtarenal aneurysm repair. The same thing happens in cardiac surgery, and they're trying to get these patients off the table and save their lives. But we can definitely be very helpful. We understand the IVUS and the endovascular technology, I think, better. And then the Middleton was asking, we have one person who's using the new Thoraflex graft that's sort of designed for these cases. And I think hopefully we'll see more and more in that, because those are pretty sweet. Then they can basically get a total arch replacement, and this never becomes a problem down the road. And it's easier to do endo on the distal part afterwards if they do that. So thanks for bringing the case. It's really good.
Absolutely. To that point, I think that it's fair to kind of think through, you said it exactly. Number one, these patients are very sick and we're treating a high mortality issue. To get the patient off the table quickly is the number one priority. But also cardiovascular surgery team was deploying the TVAR device in an antegrade fashion while the patient is on bypass. So they're not able to, maybe they don't have the flow of blood through the aorta while they're deploying this device, or know how much flow is going to be coming through the false lumen. So I think that when the patient was taken off of bypass, if you still have flow coming through the false lumen, that's going to kind of go against your outward radial force of the TVAR device and cause the collapse. Not to mention the second factor causing the collapse of it was that it was positioned right at the peak of the aorta. And so you're fighting the geometry of the curve of the aorta. So I think those two factors might have caused coarctation that wouldn't have been noticed intraoperatively during the index operation.
Just a lot of good points have been made. Just to say that was really nicely presented. Everything was crystal clear. The images you chose looked really good in terms of their, explanatory value. But when you get one of these patients that's
but you had failure to thrive. You know, when you get somebody that already there's been heroic work done to save her life, and now she's got a decubitus ulcer, a rising creatinine, and essentially multi-organ failure. That's when going back to the bedside and looking really carefully at the patient it served me so many times over my career. And I realized she was back and forth, so this is not a point of criticism. It's just a reminder of what William said earlier. To go and see the patient, and you know what I mean? It's and I think Will said this too. I think probably you know, she might have made her way back sooner had the folks where she was been really looking at her. So.
Very nice presentation. Thank you.
All right, please welcome to the podium, Dr. Anthony Mina. He is going to tell us about a comparison of non-autologous hemodialysis grafts with bovine carotid artery versus synthetic.
Great. Thank you all very much. Again, my name is Anthony Mina. I'm one of the integrated vascular surgery residents at Emory University. And thank you again to the program committee for the opportunity to present our findings. The authors have no disclosures. As we're all acutely aware, end-stage renal disease is a highly prevalent and lifestyle-limiting diagnosis. Over 800,000 US Americans are living with ESRD, and over 130,000 patients are started for treatment regarding their ESRD every year, which is particularly important in the field of vascular surgery. VII is the ideal conduit for first-time upper extremity AV access creation, but in the setting of long-standing chronic kidney disease, patients often present with poor caliber veins. So we as providers are faced with a difficult decision, which non-autologous conduit should we use? Two of the more popular options today in practice include synthetic PTFE grafts, as well as BCA or bovine carotid artery xenografts. And while they're two of the more common options, there's a paucity of data comparing the two. Arguably the biggest paper in the literature now was presented at SCVS in 2016 and published in the Journal of Vascular Surgery the following year. They looked at 134 xenografts without a comparison cohort. For their patients, the one-year primary patency rate was 32%. The one-year primary assisted patency rate was just under 50%, and their one-year secondary patency rate was 78%. The authors also looked at excision related to infection, and they saw that only 7% of their grafts required excision, which is fairly comparable to the PTF literature. And so the authors concluded that BCA xenografts were a satisfactory alternative to PTFE for dialysis access creation. Something else unique about this paper was that they looked at cost, and they compared 7mm BCA to 7mm PTFE grafts and saw, at least at the time, based on manufacturer list price alone, BCA grafts cost 36% less than PTFE grafts. Again, kind of strengthening their decision that it was a satisfactory alternative. Our only prospective data was published in 2011. It's a small cohort, just 53 total patients, 26 in the BCA cohort and 27 in the synthetic cohort. And they saw that there were no statistically significant differences in the one-year secondary patency rates between the two, but they did see a slight advantage for BCA with regard to one-year primary patency and primary assisted patency rates. So the authors concluded in this study, more than just a satisfactory alternative, they considered it an excellent option for upper extremity AV access creation. But this literature review is about it with regard to BCA grafts. There's not much data out there, and also a lot of the studies have small sample sizes. So we sought to compare outcomes between BCA grafts and synthetic grafts, number one, for first-time upper extremity AV access creation, and number two, using a more contemporary and multi-center database. We performed a retrospective review between the years of 2003 and 2022 and pulled data from 4 hospitals within a large academic healthcare network. Our primary outcomes included stenosis and thrombosis rates within 6 and 12 months. And our secondary outcomes included infection rates, mean number of interventions per access, and loss of primary patency, again at 6 and 12 months. We performed manual chart review of 295 patients. Roughly 3/4 of these patients had synthetic grafts placed. And importantly, within this cohort, the vast majority were standard use grafts, with only about 8% being immediate use grafts such as AccuSeal. There were no statistically significant differences in the baseline demographics or comorbidities between the 2 cohorts, and this included the anatomical location of the grafts. The vast majority were brachioaxillary, as well as the number of patients who had catheters prior to AV access creation. Here's our data at 6 months. Again, our primary outcomes were stenosis and thrombosis rates, and here are secondary outcomes. We'll note that patients with synthetic grafts had higher thrombosis rates at 6 months, with about 38% of synthetic grafts thrombosing at 6 months compared to only 13 of the BCA cohort. As well, there was a mean number of interventions per access that was higher for the synthetic group at about 1.7 times higher than that of the BCA cohort. And when we looked at our 12-month data, we saw that these relationships held true, where again, about 2/3 of patients with synthetic grafts had thrombosed, while only 15% of BCA grafts had thrombosed. And there was a 1.6 time higher rate of interventions per access for the synthetic group. Here are our data again for 6 and 12 months, just to highlight that there were no statistically significant differences in the infection rates or stenosis rates between the two cohorts. So in summary, at 6 and 12 months, BCA xenografts thrombosed less frequently, required fewer reinterventions, and did not require higher excision rates secondary to infection. But what about cost, since the only data we really had was that 2017 paper in JVS? With regard to that paper, as I mentioned, they looked at 7x40 PTFE and 7x40 BCA grafts. And at that time, based on manufacturer list price, there was about a $700 difference between the two in favor of BCA grafts. We looked at our institutional costs, which did include hospital discounts and bundles, and it was a slightly different story where the majority of our providers using PTFE were using 4 to 7 millimeter tapered grafts, which cost about $1,200. And the BCA grafts, the 6 millimeters, were slightly higher, between $1,700 and $1,800. So in conclusion, both at 6 months and 1 year, BCA xenografts appear to demonstrate favorable outcomes. It'll be particularly important, even though as Dr. Schneider mentioned, the cost of prospective studies, to do a larger scale study to see if BCA grafts hold these advantages over time, not only with regard to possible further complications such as aneurysmal degeneration of xenografts, but also with regard to costs, not just upfront, but reintervention related if BCA grafts truly require fewer reinterventions. Again, I'd like to thank the program committee for the opportunity to present, as well as to my mentors, including Dr. Alvey. I'd be happy to answer any questions at this time.
Dr. Cohn, please.
Yeah, Jerry Cohn, Savannah. Would you speculate that the increased interventions are primary thrombotic events? That is, would you conclude from your review that bovine grafts, which I happen to use, are less thrombogenic, and that's where the increased interventions come from a declot, rather than, obviously, as we know, intimal hyperplasia, the anastomoses or elsewhere are frequent also cause, which I can, in my mind, see why there would be a difference between the two. And then secondly, I was surprised that the cost has reversed, but I would say that one less reintervention will save Medicare a lot more money than the difference in the cost of the conduit. I'd be interested in your comments.
Yeah, absolutely. And I appreciate both questions. The first with regard to the thrombogenic nature of PTFE versus bovine. When we performed manual chart review, it did look as though the bovine product cohort had fewer primary thrombotic events. It is possible, given its xenographic nature, that it is somewhat more beneficial with regard to thrombosis in the PTFE, but there's not a lot of data from the biological standpoint to actually confirm that yet. With regard to the costs, wholeheartedly agree. We looked specifically at one manufacturer within our institution, and so maybe their costs specifically were higher, but the reintervention rates, if significant over a longer period of time, could significantly reduce costs.
Yeah, great presentation. I just wanted to know how good was your follow-up? Because, you know, dialysis patients go everywhere. They get intervened in a lot of places. So did all the patients that you had your two cohorts end up to 12 months of follow-up?
Yeah, it's a great question. It was a little arduous, but we actually performed manual chart review of each of these patients to ensure that their follow-up was being had at Emory, and that any interventions, if it wasn't done at Emory, was being performed, was documented clearly what interventions were being performed beforehand. If there was any sort of confusion with regard to that, they weren't included in our analysis.
Great talk, AJ Suhu from Augusta. We actually just switched over using BCA primarily as well. With this data, do most of your access surgeons start using this graft? And what is your antiplatelet or anticoagulation strategy after?
Yeah. So as of now, we haven't protocolized it quite yet. Certain institutions, some of the 4 hospitals within our center will use it more often than others, especially if we start to kind of unveil a more protocolized study, a longer standing prospective study. Hopefully we'll have a better regimen to further delineate what's a better option up front. With regard to antiplatelet and anticoagulation, typically monotherapy antiplatelet agents will be used, as well as, of course, a high intensity statin is needed.
Excellent presentation. Just a couple of comments. I mean, for us, I mean, we have different surgeons using different products. And the one thing about the bovine is that it feels more like a fistula. They have to learn how to stick it at the dialysis unit. So we have actually the reps go out and speak to the individual units when we put in a patient with this access. The second thing is long-term, they do get pseudoaneurysmal. And we're talking about a year or sometimes 2 years. Anecdotally, I had a patient that I replaced I put in a bovine heterograft. I replaced it at 5 years for pseudoaneurysmal changes. I again changed it 5 years later, and he has this third access with that. So, and he's done reasonably well. The other thing to be careful when you put a 7 millimeter as opposed to a 4 to 7 is the concern for steel. That is a real event. Sometimes you have to band it. So if people are using this, especially the bigger devices, I would caution them on that.
Yeah, those are both great points. Just anecdotally as well, throughout my training, I've seen a couple cases of artegraft degeneration. And so when we look at a longer scale study, that might be helpful to see exactly what those rates are. With regard to steel, there was no significant difference in our cohort between the two. A lot of our surgeons are now using the 6 millimeter artegraft rather than the 7, and maybe that's helping as well. But an interesting point too.
Yeah, I was actually going to make the same comment, Arun, but actually on the opposite end. First, my former senior partner would be happy with this presentation because he loved bovine grafts, but had an opportunity to put both in. My experience with that had been that steel was less actually with the bovine grafts, primarily because they pulse. They actually have a pulse in them, and I think sometimes that pulse reverberation may have an effect on distal flow. And with the PTFE, it's hard plastic, so steel is much more common. That said, pseudoaneurysm formation, did y'all notice anything, or do you have any comments on pseudoaneurysm formation, bovine versus PTFE? My anecdotal experience is maybe a little bit less even with the bovine, because the PTFE, you just constantly eat a hole in the prosthetic graft. But I didn't know if there's any comment there.
Yeah, we did look. There was no significant difference, at least at the 1 year mark. And so I think further follow will be beneficial to determine if there is a true difference between the two.
I'm sorry, just quickly, two quick questions. Any technical tips on making the proximal anastomosis decrease in size so that the graft is not so large? Do you guys modify it or just make it fit to the size of the graft? That's one. And two is any change on your timing for cannulation of these grafts?
Yeah, both great questions. With regard to the fit of the proximal anastomosis, our surgeons, there are a couple surgeons who will actually do very, very little beveling on the proximal anastomosis just to make it about the size of the artegraft itself to decrease that. And I think that's been pretty beneficial with regard to reducing steel rates. With regard to your second question, which was, remind me.
Cannulation time.
Yes, no significant difference between the two. There's one of our surgeons who is actually in certain circumstances allowed for close to immediate use cannulation of the artegraft. He's had fairly good success, but again, he's at the dialysis center with the access nurses helping them during that process. But he's had within 48 hours a couple accesses of immediate use for their artegraft.
I just wanted to say something really quickly. Olamide Alabi from Atlanta. So, very important point, Dr. Shervu. When you have these individuals who are going to their dialysis centers and they have a PTFE graft, they have an immediate use graft of, whatever brand, or they have a bovine carotid graft, or even cryopreserved vein, sometimes I use those. So you just got to make sure that these people know that to stick it's not the same as sticking a PTFE graft. So either sending a rep, or sometimes I myself have gone to the dialysis center and just showed them what the walls look like, show them what a needle looks like going through it, how much tougher it is to get into some of these different types of materials. It's really important that they're educated about that.
Thank you, Dr. Mina.
Our next presenter is going to speak about treatments on irreparable outflow obstruction on AV fistula. Dr. Mize.
Good afternoon, everybody, and thank you for the introduction. I'd also like to thank the program committee for allowing us the opportunity to present our work, as well as the Georgia Vascular Society. We have no disclosures. Arteriovenous fistulas with venous outflow obstruction pose a severe problem to all parties involved. the access team, the provider, but most importantly, for the patient. For the patient, this issue can cause poor clearance, prolonging their dialysis session, but it can also significantly limit their quality of life by causing severe arm pain and swelling, as seen in this picture here. Now, the venous outflow obstruction can occur in multiple locations, and some of these are easier to treat than others. For instance, you can have peripheral venous stenosis, which a lot of times we can do a simple fistulogram, balloon open that segment, potentially place a stent. But then you can also have things like venous thoracic outlet syndrome, and the hardest of all to treat are central vein stenosis or occlusion, which is where I'll be focusing my talk today. So with regards to central vein stenosis or occlusion, what are our potential treatment options? Well, you could consider open management for this issue. For instance, you could do a first rib resection if it was for TOS. You could also do an SVC reconstruction via sternotomy, as seen here. But oftentimes, a sternotomy is a pretty morbid procedure for most patients, not to mention for our vascular patients and especially our dialysis population. You could also occasionally do bypasses from the subclavian to the internal jugular vein. There are also hybrid options where you can do recanalization and endoreconstruction of the occluded portion, as seen here. And then you could potentially place a fistula or a graft on the ipsilateral side that you just opened up. But what if you go through all of this trouble and you get it open, but you can't keep it open or reopen it after it clots off again? And that's what I'm here to discuss. So the general dogma in this situation for untreatable outflow stenosis in a patent but dysfunctional fistula is you could ligate the fistula, move to the other arm, and essentially start over. Or you could place a graft, but we know compared to autologous vein conduits, they generally have shorter longevity. And once a fistula matures, they generally have lower revision rates and tend to be better than grafts in general. Or you could completely abandon access options in the arm, try to create access in the legs, or consider placing a catheter or discuss with your patient peritoneal dialysis. But I'm here today to ask you to stop thinking of this dogma and ask yourself, why would I start over and move to a new arm with a 2 to 3 millimeter vein and fingers crossed, hope that it matures in 4 to 6 weeks, or potentially have a slew of other operations to try and get it to mature? Or why would I place a catheter in this patient for dialysis that likely caused this problem to begin with? Instead, I want you to think about recycling that vein, translocating it to the new arm, and making one arm's trash another arm's treasure. So at our institution, we have successfully performed this procedure in 4 patients, ages ranging from 43 to 80 years old, and they all had patent fistulas and severe symptomatic and most importantly, unreconstructible central venous outflow obstruction. They had undergone multiple venograms, multiple attempts at balloon angioplasty, multiple stent placements. So if you're thinking about taking on this endeavor, there are a few things you want to do preoperatively to help prepare. You want to make sure you do a contralateral upper extremity and central venogram prior to planning this translocation so that you're not running into the same issue on the other arm if you translocate it. You also want to make sure to do a surgeon-performed ultrasound to assess for optimal inflow and outflow vessels on the receiving arm. So once you decide you want to go ahead and move forward with the procedure, you'll take the patient to the OR, you'll expose the fistula and get a sense of the length of the new autologous vein graft that you'll be working with. You'll then harvest the fistula and remove any retained valves and intimal hyperplasia. Once you've completely harvested and optimized that vein conduit, you'll then move to the receiving arm, making 2 incisions over the artery and vein that you want to do your anastomosis to and make a tunnel between those 2. And then you'll first perform your arterial anastomosis, and we recommend doing so with the parachute technique. time from implant until cleared for use is 45 days, but granted, there was an outlier with one patient being hospitalized for one of his comorbidities outside of dialysis. And in fact, one of our earliest patients was able to use this conduit in 20 days postoperatively. And we believe it's a durable alternative as well. Our average primary patency is 388 days, and we have 100% primary assisted patency at 1 year in this population. And most importantly for our patients, all of them had complete resolution of their original symptoms. So in conclusion, while this procedure can be complex and time intensive, we do believe that it is durable given the results in our case series that I presented here today. And we believe it's a far superior alternative to ligation of a mature autologous venous conduit. And like I said, it provides our patients with improved quality of life and symptom improvement as well. And you can take an arm that was once large, painful, and plethoric like this one, and give the patient back their normal arm and an autologous conduit simply by recycling that vein. Thank you.
Thank you. That was great. I'm a community surgeon in a rural community that sees a lot of these, and will not have 6 hours as a solo practitioner, but I found it very, very good to have that as an option. What are you doing with the vein after you recycle it in the back table to prepare it? As far as heparinization, flushing, it's a large vein with a lot of tortuosity. How do you prepare it prior to reimplanting?
Yeah, so prior to implanting, really just making sure that we're repairing the pseudoaneurysms in a timely fashion. And of course, we use heparinized saline to help us in that endeavor. But really, there's no big limitation with that regard that I saw, at least in our experience.
I heparinize a patient once, the moment of harvesting, and then I just leave them heparinized until I put it in. I assure you that you as a fully trained vascular surgeon could probably half the time as you're doing the teaching. It probably takes a lot longer. So what I do is I look at the length of the vein that I have, and like we showed, if they have a radiocephalic or brachiocephalic, and this is all aneurysmal and disgusting, but this portion right here is beautiful. You just take that piece and move it over. It's really easy. But if not, then you just resect obviously damaged parts, or I do aneurysmorraphies to sort of bring together the parts that are usable. But we've been able to sort of reconstruct either by end-to-end resections or by just aneurysmorraphies in the middle.
Thanks.
One quick last thing, as far as the time to access, the patients that are hospitalized and sick and all this sort of stuff, stay in the hospital a long time, I'm convinced you could probably access this within 2 or 3 days. The one patient, once I got excited about it, I said follow up in 4 days for clearance, and my nursing staff in clinic said he never sees patients that had fistulas in 4 days, so they canceled it and pushed it out to a month. So I almost had it, but I don't.
Thank you all.
Thank you. We'll turn it over to Dr. Patel and Dr. Burkett.
Good afternoon. Let's keep us on track. I'm Allison Burkett, community surgeon in Warner Robins, Georgia, vascular surgery.
Right, thanks for everybody for staying and sticking it out. I'm Siddharth Patel, a vascular surgeon at Northside System, primarily practicing in Cumming, Georgia now.
Great. Really grateful for these young student doctors and their presentation. I'd like to introduce student Dr. Jordan Baker to discuss indications for urgent and emergent hemodialysis.
Good morning, everyone. My name is Jordan Baker. I'm a fourth-year medical student at the Medical College of Georgia. I want to thank the GBS for giving me the opportunity today to speak at this conference. And we're going to be discussing indications for urgent and emergent hemodialysis. So per the National Kidney Foundation, I'm sure we're all familiar with the typical AEIOU mnemonic for indications for emergent dialysis in patients who don't have prior end-stage renal disease. However, based on prior literature review, there's minimal exploration into actual time intervals on when patients should actually be initiated on hemodialysis. And in some community hospitals, vascular surgeons are strained and actually required to place some of these temporary catheters in patients who need emergent hemodialysis. And as we all know, or hopefully for me, starting residency next year, vascular surgery is quite a demanding field. And so especially with call schedule, you're almost always expected to be busy. And this also can lead to a resource overload, especially in the middle of the night, for individuals other than the surgeon who are responsible for the patient's care. So we identified two aims for this study. The first one was to try to recognize and identify patients who are candidates for emergent versus urgent hemodialysis. We defined emergent hemodialysis as initiation of hemodialysis within 2 hours of temporary catheter placement. And then urgent hemodialysis, individuals who undergo dialysis after 2 hours of vas cath placement. And then ultimately, we wanted to determine which patients could safely undergo hemodialysis during daytime hours. So we hypothesized that with the exception of hyperkalemia, most individuals can undergo hemodialysis greater than 2 hours after temporary catheter placement, and that there will be minimal or no change in ventilatory requirements, mortality, and then arrhythmias that require ACLS intervention. We did a retrospective cohort study. We did this through a chart review using the EMR database at Piedmont Athens Regional Hospital in Athens, Georgia. We collected data from 2020 and 2021. Our only exclusion criteria for this were patients that had known end-stage renal disease. And we divided these patients into 4 cohorts, which included acute kidney injury with hyperkalemia, with metabolic acidosis, and then ultimately patients who had both hyperkalemia and metabolic acidosis. This is a table here that shows patients who underwent emergent hemodialysis, and then it also looks at 3 variables, which was inpatient mortality, mechanical ventilation, 24 hours after the initiation of hemodialysis, along with the arrhythmias that required ACLS intervention. And then we also wanted to see which patients were on max medical therapy for hyperkalemia prior to initiation of hemodialysis. And this is data of patients who received hemodialysis urgently, so greater than 2 hours after temporary catheter placement. And as you can see, what I've highlighted here are those that had noticeable increases in rates of mortality, ventilator use, and arrhythmias. So what I did was I made these graphs to compare patients who had received hemodialysis emergently and urgently. And as you can see, for ventilatory requirement rates, patients who had received hemodialysis urgently and had hyperkalemia and metabolic acidosis had a marked increase in persistent ventilator use after the initiation of hemodialysis. And subsequently, looking at arrhythmias that required ACLS intervention, patients with hyperkalemia and hyperkalemia with metabolic acidosis who underwent hemodialysis urgently had marked increased rates as well. And then this graph just shows comparisons of patients who received hemodialysis emergently and urgently that either had hyperkalemia or hyperkalemia with metabolic acidosis and were on max medical therapy. And as you can see, as patients underwent hemodialysis urgently, a smaller percentage of them were actually on this max medical therapy. And then ultimately, and most importantly, is the mortality rate. So patients that had hyperkalemia or hyperkalemia with metabolic acidosis
did have marked increase in mortality if they underwent hemodialysis urgently. So I think some conclusions that we can take from this study, preliminary speaking, is it does suggest, based on the trends, that patients who do have hyperkalemia or hyperkalemia with metabolic acidosis would benefit if they were to receive hemodialysis within 2 hours of temporary catheter placement. And, you know, based off this data, the reason why is because patients with these conditions have higher rates of arrhythmias, persistent ventilatory requirements, along with ultimate increased risk of mortality. And I think it's also worth noting too that a significant portion of these patients, they're not on max medical therapy for hyperkalemia prior to the initiation of hemodialysis. And then inherently too, this is a relatively sick patient population, so the mortality rate is going to remain high. However, the study does not come without limitations. As I'm sure we're all aware, 2020 and 2021 was plagued by the COVID-19 pandemic, and we also were able to stratify these patients based on their cause of death. And the vast majority of these patients did die from a COVID-19 related illness. And we believe that there could be some confounding effect due to this. However, we are pulling data from 2022 and 2023 to see if those trends actually continue. We also did not stratify the severity of hyperkalemia. And as we know, elevated potassium levels in the blood, especially if they're much higher, can lead to a more increased risk of developing fatal cardiac arrhythmias. And then also, you know, we really focused on hyperkalemia and metabolic acidosis from an etiologic standpoint. Other common causes such as uremic pericarditis and volume overload, the patient population within those groups were really small, like less than 5 patients. And we used the nephrology progress note or consult note to actually determine the diagnosis. And a lot of them just had generalized acute kidney injury. And so we kind of funneled everything else into that group. Again, I want to thank the Georgia Vascular Society for allowing me to speak here today, and also Dr. Christopher Everett. He's helped me make this radical transition from orthopedic surgery to vascular surgery, and I can't thank him enough for his service. Thank you.
Thank you for this presentation. And as someone who's often called on a Friday afternoon to put in a catheter, it'd be great to see if you could develop some kind of objective stratification, because everyone's an emergency. The hope is that maybe the outcomes of your research would develop something we can look at for objective parameters. Like, does this patient really need this now? And why did you choose the timeframe based on catheter placement versus consult or arrival to the hospital? What was the idea there?
That's a great question, actually, and Dr. Everett and I had discussed that extensively. The main reason why we went from VASCATH placement to actual hemodialysis initiation is because there wasn't a ton of accuracy with when that consult note or progress note was placed within the EMR, and there was no better way to actually determine the time of that. There were many instances where actually the nephrology consult note or progress note was placed multiple hours after the initiation of hemodialysis and the VASCATH. And so we thought that given accurate time parameters, this would give us the best estimate regarding the initiation of hemodialysis.
Hi, Chris Ramos, Emory at Grady. Were any of your values statistically significant? Did you do a t-test or something? And also, did you find any factors like the time of day that the catheter was placed as a reason why dialysis wasn't started immediately? Was it on the weekends? What factors went into, you know, why patients were started on dialysis right away or not?
That's a great question, Dr. Ramos, and thank you. So regarding, you know, the factors of patients, you know, the fact that they were initiated on hemodialysis much later, we did find that within the chart, patients who had a VASCATH placed, you know, in the middle of the night, so in between 12 or 4 a.m., the vast majority of those patients actually did not receive hemodialysis until like 1 or 2 p.m. the very next day, which I'm sure from a vascular attending standpoint can be frustrating, because I know that a lot of y'all are overworked, and that's been topic of discussion for a lot of us during this weekend. And do you mind repeating your first question, Dr. Ramos? Sorry.
Did you do any statistical analysis, any p-values, t-tests?
We did a chi-square, basically just comparing the binomial variables in the 2 time interval groups. And although nothing was statistically significant, there was a noticeable trend. Can kind of go back here and just show that real quick. And so as the variation got bigger between the groups, the p-values did start to decrease. But I do think that once we gather 2 more years of data, hopefully we can reach that 0.05 mark, which is another reason too why I wanted to preface by stating that I suggested that this data could be valuable as opposed to, determining a causal relationship.
That was very nicely presented, Jordan. The evolution of this paper is actually very interesting in that, we as vascular surgeons are the firemen in the hospital, and often what's urgent to other specialists are not what we would consider urgent. And I think the data bears this out. When the nephrologists ask us to place about a dialysis catheter, I know there are 5 or 6 other specialists within the hospital that have privileges to do central lines. No one else is really willing to place them at times. And that burden falls directly on us. And we're also dealing with the diabetic foot wounds in the middle of the night, and the vascular trauma can be overwhelming at times. So my goal was to help identify, are there patients that can be put off to the daytime hours? We have a very robust support network of mid-level providers who help us place these catheters during the day, and even some young enterprising intensivists who are willing to place them as well. So the goal was to identify, can it be safely offloaded to the next day? Are there patients that really need to be done in the middle of the night? And the first thing we found was, good Lord, a big portion of these patients aren't even dialyzed within a couple of hours when we place the catheter. So why are we getting called in the middle of the night to put these catheters in when there's all these inherent delays in the system and they don't dialyze for 6 or 8 hours? So that's where the 2-hour time frame kind of came from. I think where I'm going to take this data is go back to our nephrologists and say, look, you guys really need to pare this down. I think you guys have been a little bit, we've accommodated you a little bit too much, and that we really need to focus down to the patients who really need this. We're willing to provide the service, but it's got to be the ones that really need it in the middle of the night. And that was the kind of goal or influence for the data. And I think it kind of bears that out. Thanks, everyone.
Thank you.
Thank you. I'd like to next invite Dr. Catherine Bombley to discuss regional anesthesia for arteriovenous fistula creation significantly increases venous diameter.
Thank you for the introduction. Good afternoon. I think it's good morning, good afternoon. I'd like to thank the Georgia Vascular Society for this opportunity. I'd also like to thank Dr. Ramos and the vascular surgery team at Emory and Grady for making this research endeavor possible. Patients with end-stage renal disease requiring dialysis will undergo evaluation for permanent dialysis access creation, generally in the form of an arteriovenous fistula. We have no disclosures. Preoperative assessment often includes ultrasound or vein mapping, typically conducted by a vascular technologist. This preoperative ultrasound is employed to examine the arterial and venous anatomy, aiming to pinpoint a suitable location for the creation of a fistula. As surgical planning progresses, the process extends into the operating room, where close collaboration with anesthesia colleagues occurs. Within this setting, the surgical team can coordinate the use of various anesthetic methods, including regional blocks. Despite regional blocks being acknowledged for their vasodilatory effects, there is a notable absence of data evaluating their influence on procedures related to fistula creation. The use of intraoperative ultrasound into the realm of surgical planning also remains largely unexplored, with its application in this context remaining inadequately documented. Consequently, there is a limited pool of data available for assessing potential alterations to surgical plans following the introduction of intraoperative ultrasound and the implementation of regional anesthesia. To address these gaps, our team conducted a study comparing preoperative target vein diameters with intraoperative measurements after regional anesthesia administration. We also assessed whether these measurements led to changes in the surgical plan and fistula patency outcomes.
We hypothesize that regional anesthesia will cause a significant increase in target vein diameter when comparing preoperative ultrasound to intraoperative ultrasound measurements. To investigate our queries, our team evaluated patients undergoing permanent dialysis access surgery for the first time at a single center safety net hospital from 2012 to 2019. This was carried out through a retrospective chart analysis. Patients included were those who received regional anesthesia and had preoperative and intraoperative vein mapping. We also collected perioperative details to include fistula type, primary and primary assisted patency data, and preoperative and intraoperative target vein diameters. Through the chart analysis, we identified over 400 patients that underwent first-time permanent dialysis access creation in the selected time period. Out of these patients, 149 met criteria for our study, and we were able to obtain data on patency status on 138 of them. 11 patients were lost to follow-up after their initial surgery. Patients were excluded from our study if they received general anesthesia, underwent AV graft placement, or lacked documentation for both postoperative and between both preoperative and postoperative vein measurements. Excuse me. Here we present the patient demographics from our evaluation with a large population of African American and Hispanic patients. Regarding fistula types, 50% of patients had a brachiocephalic configuration, while a minority underwent the single-stage brachiobasilic configuration. When comparing preoperative and intraoperative target vein diameters, we observed an average preoperative measurement of 2.5 millimeters and an average intraoperative diameter measurement of 3.9 millimeters. There is a significant difference between these two groups. When assessing modifications to surgical strategy comparing preoperative and intraoperative ultrasound measurements of the target veins, it became evident that nearly half of the patients had initially been planned for a more central access site or graft placement during their preoperative evaluation. Out of the group of patients who underwent radiocephalic fistula creation, 20 individuals, constituting more than 75% of this group, were scheduled for a different access surgery. Likewise, 31 patients, comprising about 40% of those who underwent brachiocephalic fistula creation, were also scheduled for an alternative access surgery. Furthermore, 20 patients, accounting for 40% of either single-stage or two-stage brachiobasilic procedures, were planned to undergo an arteriovenous graft placement. Upon evaluation of fistula patency rates, we found that each configuration achieved at least 54% of primary patency and at least 74% achieved primary assisted patency. There was no significant difference in primary assisted patency between the groups. Our investigation, of course, had some limitations. Firstly, it's based on data from a single center, which limits the applicability to every surgical practice. Furthermore, our population is from a safety net institution that primarily serves low-income, uninsured, and undocumented individuals. In such a setting, limitations arise due to challenges in patient follow-up, often associated with limited access to healthcare and affordability concerns. As previously noted, we identified 11 patients who were lost to follow-up following their initial surgery. This circumstance is likely to have an effect on their outcomes required for dialysis access surveillance and imposes limitations on our analysis. Finally, recognizing operator variability during ultrasound vein mapping and interpretation is vital. Variations can occur at the technologist level and in the training disparities between vascular technologists and surgeons. These distinctions can potentially influence the assessment of target vein anatomy for fistula creation. In conclusion, our investigation has revealed that regional anesthesia significantly augments target vein size in the context of fistula creation. These findings underscore the crucial role of anesthesia type in shaping surgical strategies and influencing patency outcomes. We also noted that alterations to the surgical plan occurred in nearly half of our patients due to intraoperative vein measurements. Due to these findings, we strongly advocate the implementation of intraoperative vein mapping as a valuable tool for surgeons in determining the most suitable access site for their patients. This approach holds the potential to enhance the overall success and efficacy of permanent dialysis access procedures, ultimately improving patient care and outcomes. Thank you for your attention, and I'll be happy to take any questions or comments.
Catherine, thank you for that wonderful presentation. Were you able to compare the preoperative and postoperative or intraoperative ultrasound measurements in the groups that did not receive the regional anesthesia, either the local or the general anesthesia group, to see if they're also getting that same sort of increase? Is it because they're coming in for surgery, they're getting hydrated in the pre-op holding area?
Great question. Thank you. Our initial database of about 400 patients, we did have that general anesthesia, or that wasn't an exclusion originally from our database that we created over the past couple of years, where we did account for their intraoperative and preoperative measurements. However, we didn't combine that in our study here. But that would actually be a good, to expand and to be able to compare both groups and types of anesthetic modalities. I think that would be interesting to see how that, how they differed, or if they were similar.
In a similar vein, to do a comparison group, was the ultrasound done after regional anesthesia done by ultrasound technologists or the surgeons? And did the surgeons do the pre-op? You know what I mean?
Mm-hmm. No, great question. I believe at our center at Grady, I believe these intra or preoperative ultrasound measurements were done by technologists. And then intraoperatively, they were completed by the surgeon. So I think that can create, there, like I said, some differences, I believe, or, I would assume because of the training, from what I've observed in my time with vascular surgeons intraoperatively, and how that might differ from preoperative measurement.
Chris?
Sir.
Go ahead. Thank you.
Thank you. Thank you for your question. I personally have not thought about how I would do that in practice when I am practicing as a surgeon. But I think what I've observed in private practice and in academic surgery, I have seen those types of modalities employed preoperatively. I think it just would depend on the practice pattern, who's the access surgeon, and if they're actively thinking about this data like preoperatively, to compare it to if there was even preoperative vein mapping to confirm, especially if you had a patient coming in where you're handed their vein mapping study with no viable conduit for fistula, and you're automatically thinking a graft, or you might be thinking that, but just to confirm those preoperative findings, I think that would be, I think it's feasible. I've seen it a lot in academic surgery where the surgeons are performing on table mapping, or, like you're suggesting, maybe in like in pre-op holding, they could be analyzing the veins for possible access. Thank you.
Thanks. Just one quick last question.
Yeah, just a comment, Chris Reynolds, Grady, good job, great job, Katie. So yeah, we're very fortunate to have a good great anesthesia group. About 98% of our patients undergo supraclavicular block and are successful. We have a very low rate of patients that require general anesthesia if the block fails or so. And to answer Dr. Escobar's comment or question, yeah, there's a difference in techniques between the ultrasound tech and what the surgeon does. I'd like to say that what we see in the OR as a surgeon is going to take us further than what an ultrasound tech shows you. So I think it's just the whole point of this study was just to say vascular surgeons should be performing their own vein map intraoperatively, not just go off what the pre-op vein map and plan was, because the plan will change.
Thank you both. Good job.
Thank you.
Next is student Dr. Miles Morgan discussing endovascular salvage for early failure of arteriovenous fistulas.
Hi, thank you for that introduction. I'm Miles Morgan, a third-year medical student at the AU-UGA Medical Partnership, and I'm here to discuss the endovascular salvage for early failure of arteriovenous fistulas. We have no disclosures. So as a bit of background, a significant portion of arteriovenous fistulas fail before successful cannulation or within 3 months of usage, and this is termed early failure. The most common etiologies of this include accessory vein formation and stenosis of the venous outflow. The most common treatments for this include percutaneous dilatation, thrombectomy, accessory vein obliteration, and stent placement. However, there are other treatments used, and this is just the most common ones. But why salvage? And not just place a perm cath and create a new access. In 2011, Miller et al. Published a study looking at 148 thrombosed early failure AVFs. 140 of those AVFs were intervened on, and 119 were successfully declotted. Their study showed overall secondary patency rates, as in those fistulas whose patency can be maintained with interventions, of 80% at 24 months. Patency of these AVFs in turn leads to decreased rates of perm cath placement and usage, and of course, those associated decreased rates of infection and complications. However, that paper also showed that those fistulas required 2.78 interventions per access year to maintain. In addition, the overall primary or intervention-free patency rate was only 29% at 6 months. So our project was a retrospective review of 4 cases of successful endovascular salvage of 4 thrombosed early failure AVFs. Case 1 was a 65-year-old male with a history of right nephrectomy, secondary to renal cell carcinoma, end-stage renal disease, and GU cancer, who had started dialysis 2 months prior via a right IJ perm cath. A preoperative workup showed adequate anatomy, and a left brachiocephalic fistula was placed. 2 months later, he presented with AVF thrombosis, even though surveillance ultrasound demonstrated evidence of maturation, with the fistula dilating to 4 to 6 millimeters. He was placed on anticoagulation, given his cancer history, and recommended for endovascular salvage and percutaneous thrombectomy. In the initial procedure, retrograde access was obtained in the cephalic vein, and here we can see the occlusive thrombus in the cephalic vein with a deep vein filling via a collateral. The arterial anastomosis, was crossed with an 014 command wire and an Abercross catheter with an upper extremity angiogram showing no flow limiting lesions of the brachial artery. An over-the-wire Fogarty was used to declot the arterial anastomosis. Balloon angioplasty of the juxta-anastomotic stenosis was subsequently performed with serial inflations of 5 and 6 millimeter angioplasty balloons. Patency was then restored to his AVF with infiltration of 2 milligrams of TPA to treat residual thrombus. He was seen 2 weeks later with a patent but still immature AVF, and at that time he was given an upper extremity tourniquet and exercise instructions to facilitate maturation. 3 months after that intervention, it was determined that his AVF had an outflow occlusion with reconstitution in the upper arm. A fistulogram was performed at that time, demonstrating occlusion of the mid-arm cephalic vein. The occlusion was then crossed with an 014 command wire and Abercross catheter, and balloon venoplasty was performed with a 5x80 balloon. After the venoplasty, some residual stenosis was identified, and the stenosis was treated with a 7x100 Gore-Vivon self-expanding stent and post-dilated with a 7 millimeter conquest balloon. During that same procedure, juxta-anastomotic stenosis was also identified and treated with a 6x40 millimeter Mustang balloon. At his 2-week follow-up, he was given permission to use his AVF. Our second case is a right-handed 43-year-old female with end-stage renal disease secondary to hypertension and diabetes with a prior failed left radiocephalic AVF. Unfortunately, this AVF was found to be occluded and intervention could not be offered due to upcoming ophthalmologic surgery and contraindication to anticoagulation. She subsequently underwent placement of a brachiocephalic AVF and was placed on dual antiplatelet therapy. On postoperative day 63, an AVF duplex showed a mature AVF. However, it was too late to cannulate and was transposed. Following healing, she was able to use the AVF, but continued to have difficulty cannulation. On exam, she had a thrill only in the proximal segment, which was concerning for a distal occlusion, and the decision was made to perform a fistulogram for endovascular salvage. Her AVF was accessed antegrade just distal to the arterial anastomosis. A command wire and Navier-Cross catheter were used to cross the thrombosed segment of the cephalic vein, and a central venogram demonstrated patency of the left subclavian and brachiocephalic veins. A 6x80 conquest balloon was used to perform serial venoplasty along the cephalic vein with multiple areas of stenosis identified. Post-venoplasty demonstrated residual thrombus and stenosis and was subsequently stented with a 9x100 5-on stent graft and dilated with a 7x80 balloon. The excess was visualized to be patent, and on her 1-month follow-up, she had been using her left upper extremity AVF without issue for 3 weeks, and her permacath was removed at that time. Case 3 is a 65-year-old male with end-stage renal disease on hemodialysis with 2 prior failed fistulas. He underwent left radiobacillic AVF creation in November 2022, and he was then seen in January 2023. But unfortunately, his ultrasound performed in radiology was unable to be used because his previously ligated radiocephalic AVF was scanned instead of his radiobacillic. His physical exam at that time indicated poor flow in the AV fistula with only a faint bruit present, and he was scheduled for a fistulogram. Pre-procedural ultrasound demonstrated high-grade stenosis of the juxta-anastomotic segment of the left radiobacillic fistula. The bacillic vein was accessed retrograde through the anastomosis to the radial artery. The stenosis was then treated with serial dilations of 5x100 and 6x40 balloons with improved patency of the arterial anastomosis. He was seen in clinic 2 weeks following the procedure with a patent left upper extremity AVF and instructed to begin cannulation. His tunnel dialysis catheter was removed 1 month later. Case 4 is a 50-year-old male, prior donor nephrectomy to his brother, with a history of hyperhomocystinemia, HIV, hypertension, SVC syndrome, and ESRD on hemodialysis. He had a prior history of a PD catheter infection and 2 prior failed right upper extremity accesses, with 1 being a fistula, the other being a graft. A left brachiobacillic AVF creation was performed by transplant surgery, and he presented on post-op day 19 with thrombosis. A percutaneous thrombectomy was unsuccessful by interventional radiology, and vascular surgery was consulted. Retrograde access of the left bacillic vein was obtained at the mid-arm, and a forefront sheath was placed. The occlusive thrombus was crossed with a glide catheter and 014 command wire. And the proximally occluded bacillic vein was treated with a 5x40 Sterling, followed by a 7x20 Evercross balloon. The completion image showed a patent AVF with brisk flow, and he was discharged on Eliquis. The patient would subsequently undergo balloon angioplasty of the left brachiobacillic vein for central stenosis, but has since demonstrated patency. In conclusion, based on these cases and previously published research, salvage of early failure AVFs is possible. However, their long-term patency needs to be further examined along with the value between salvage and creation of alternative access. Thank you, and I can now take any questions.
Thank you very much. You know, in the spirit of fistula first, we get this. But my question is, after your review and preparation, review of the cases in preparation of this abstract, when do you think we should start to do aggressive follow-up? I mean, at 22 days, that's within 3 weeks of the placement. Wounds sometimes haven't healed. Is this a recommendation or future recommendation to do ultrasound at the first follow-up visit? Have you guys developed any kind of thoughts about the algorithm with regards to that?
So I'll let Dr. Suhu answer that for any of the Augusta-based, but in the literature, it sounds like even with fairly aggressive follow-up, there wasn't really any significant change in rates of thrombosis.
Yeah, we pretty much see these people anywhere 2 to 4 weeks with a good physical exam and a duplex ultrasound. And we're trying to basically get them cannulated through their fistula and the catheter route, but pretty much 2 to 4 weeks.
You reported fairly good outcomes at a month. Do you have a longer term outcomes like at 6 months and a year?
So a lot of these were done fairly recently. So no, we don't have those outcomes just yet.
Thank you.
Next up, we have Matthew Long, a 4th-year medical student at Augusta, presenting primary inferior vena cava leiomyosarcoma, a rare cause of retroperitoneal mass.
Good afternoon, everyone. My name is Matthew Long. I'm a fourth-year medical student at the Medical College of Georgia. And as was mentioned, I'll be discussing a rare cause of retroperitoneal mass, which for our patient turned out to be primary inferior vena cava leiomyosarcoma. Having the same problem here.
Use the other remote.
Thank you. Okay, I have no financial disclosures with this presentation. So for some context, as we know, large veins have three distinct layers. The one that we care about today is the tunica media, as it is comprised of smooth muscle cells, which ultimately give rise to this malignancy. So it is a malignant tumor, and unfortunately, it is often aggressive. It is fairly rare, accounting for approximately 1 in 100,000 of all adult malignancies, with less than 450 documented in the literature. And I think that that highlights the importance of documenting and presenting on these cases to expand the understanding as we go forward. It occurs approximately 3 times more frequently in females, and it generally presents in the 5th and 6th decades of life. Unfortunately, about 50% of patients will present with metastatic disease at the initial diagnosis, with the liver and the lungs being the most common sites. These tumors are further classified depending on the segment of the IVC that they involve, as well as the growth pattern that they display, with the IVC being divided into 3 segments. Segment 1 is the most distal portion. It is the infrarenal IVC up to, but not including the renal vessels, the renal veins, excuse me. And then segment 2 will begin with the renal veins, and it extends proximally up to the major suprahepatic veins, but not including them. Segment 3 begins with the major suprahepatic veins and extends even up into the right heart occasionally. There's frequently overlap between the segments with these tumors involving more than one. As far as the growth pattern, extraluminal is the most common. Then there's also intraluminal or mixed patterns. And contrary to many sarcomas, the histologic grade is actually not very strongly associated with the prognosis for these patients. The reason for that is likely twofold. One, unfortunately, as well, no histologic grade portends a great prognosis with this particular malignancy. The second reason also being that there are other factors that are more important for prognosis, such as segment 3 involvement, intraluminal growth pattern, Budd-Chiari syndrome, leg edema, and occlusive IVC disease. All of these are associated with a poor prognosis more so than necessarily the histologic grade. With regards to clinical features, this is heavily dependent upon the segment that is involved or the growth pattern, which makes sense anatomically. Segment 1 is generally fairly nonspecific, maybe some lower extremity edema, with segment 2 generally carries a better prognosis because the abdominal pain will present sooner and therefore patients will get evaluated sooner. Renal failure may also result if the renal vessels are involved. And with segment 3, it frequently presents with Budd-Chiari syndrome. The nonspecific findings associated with this are typical of most malignancies: fever, weight loss, night sweats, etc. And abdominal pain is the most commonly observed. Some data sets say approximately 96% of patients. The intraluminal growth pattern also will generally present earlier with symptoms of IVC obstruction and pulmonary embolism, cardiac arrhythmias. As far as the differential for this, angiosarcoma should be considered, although it is far more rare. And then renal cell and hepatocellular carcinoma, both of which can extend into the IVC and therefore can be confused with this relatively easily. And then pancreatic head tumors and duodenal tumors, just given their vicinity, they can be confused on imaging as well and should be considered. So for our case presentation, we had a 56-year-old female. She presented with persistent right-sided abdominal pain to an outside facility where she obtained a CT abdomen and pelvis, which revealed a 7-centimeter enhancing periduodenal mass. That prompted her referral to our surgical oncology clinic, where she was first evaluated by us. Her past medical history was only significant for Crohn's disease, status post left hemicolectomy, and colostomy. At her initial surgical oncology clinic visit, her only complaints were right-sided abdominal pain and flank pain, and as well as a little bit of fatigue, but no other symptoms. And her physical exam was unremarkable, including no lower extremity edema. As I mentioned with her workup, she did have that CT at the outside hospital. She also went on to have a CT-guided core needle biopsy that revealed smooth muscle neoplasm, but the pathologist commented unable to rule out sarcoma and needed a larger tissue specimen. And then a CT chest was performed to rule out intrathoracic mets, and that was negative, as well as an MRI was performed for further surgical planning as well as staging. And that showed the periduodenal lesion that you can see here with a red arrow, most likely representing a low-grade sarcoma. One of the most important parts of this patient's preoperative evaluation as well was that they were seen in clinic by urology, vascular surgery, and surgical oncology prior to the day of surgery to help with joint surgical planning. Some further preoperative imaging, you can see here the IVC in blue, the aorta in red, and here's the mass in green. And as you can see, it is a fairly large mass abutting into the adjacent structures. As far as the surgery, a midline laparotomy was performed, and it revealed that the mass was coming from the anterior wall of the IVC in the segment 2 portion. The dissection was continued to exclude the duodenum in the right kidney, and their involvement was excluded. And then control was obtained of the IVC with proximal and distal clamping, after which the tumor was removed in block with the anterior wall of the IVC. The gross specimen, which you can see is kind of a smaller picture here, but measured 9.5 centimeters. And then a repair was done with a patch angioplasty and bovine pericardial patch with good venous return afterward. So the postoperative course, the path report did confirm leiomyosarcoma with all negative margins, and the patient was discharged home on postoperative day 4 after an uneventful hospital stay. She was discussed at our sarcoma tumor board, and it was elected to proceed with surveillance only for her. At her 4-month hem-onc clinic visit, she reported healing well from surgery and did not have any new complaints at that time. And an MRI was done at around that same time, which showed no evidence of disease recurrence. As far as discussion, it's important to note that surgical resection is the only curative treatment, and negative margins are extremely important for patient outcomes. The 3- and 5-year survival with negative margins has been reported to be around 76% and 68% respectively versus 0% with positive margins. Of course, this data will vary slightly depending on the case series you review, but the trend remains that the negative margins is paramount. And then also coordinated surgical planning between various surgical specialists is essential. Our particular case was a joint operation with surgical oncology and vascular surgery with urology on standby. But if you have segment 3 disease, you may need to do a simultaneous sternotomy and laparotomy. So cardiac surgery may need to be involved as well. And there remains no clear consensus regarding the role of adjuvant or neoadjuvant treatment so far. However, some studies suggest that neoadjuvant radiation may improve the resectability of poorly resectable tumors. One of the most debated topics in literature with regard to this is whether or not reconstruction is even beneficial or necessary. So I'll touch briefly on the pros of each. The benefits of reconstruction, of course, you're restoring the native anatomy, so you should have improved venous return and therefore improved cardiac output. Additionally, if you have a simple ligation involving segment 2 or higher, or a segment 2, then you often will have to remove the right kidney just because it doesn't have sufficient collateral circulation, even if it's not involved with the cancer. So with reconstructing, you can retain both kidneys generally. If you do decide to reconstruct, primary repair, PTFE or Dacron grafts, as well as patch angioplasty are all good options. With regards to simple reconstruction without, simple ligation without reconstruction, the benefits are that you can have a wider local excision, which some would argue might be more oncologically safe, as well as you can remove the distal portion of the IVC, which is a frequent site of disease recurrence. And so you're removing that potential recurrence in the future. As well, you avoid the risk of any graft materials being in place. Those who do have symptoms with this, generally those symptoms will resolve within 3 months post-operatively. Obviously, this is not ideal, or not everyone would be an ideal candidate for this. So when patient selection is considered, some factors that are beneficial for not reconstructing would include more distal disease. So segment 1 is ideal. Segment 2, depending on the degree of collateral circulation, may be possible. And then as well, slowly progressive disease with significant IVC obstruction. Both of those things favor collateral circulation formation and therefore are good things for those who would not reconstruct. Additionally, you can do a test where you clamp the IVC, you give 20 milligrams of IV Lasix, and then you follow the urine output for 30 minutes. If it exceeds 100 cc's within that 30-minute period, it suggests that they would do well without reconstruction. So in conclusion, surgical resection is the only curative treatment for IVC leiomyosarcoma, and negative margins are paramount for patient outcomes. IVC reconstruction with bovine pericardial patch angioplasty has been safe and effective for our patients so far, and we wish for the best and hope it will remain that way. And a multidisciplinary care team is essential for achieving optimal patient outcomes. And then the benefits and risks of reconstructing versus not should be considered on a patient-by-patient basis. Thank you. Any questions and comments?
If our next speaker could go ahead and make their way up, Brendan Mahoney. Matthew, thank you for that great talk. Wonderful presentation. Clearly, this is a rare case that I think most of us probably will never see in our careers. So thank you for bringing this to us with a very insightful presentation. I think it's educational for everybody. Unless there are any pressing questions, I think in the interest of time, we'd like to go ahead and move this on to the next talk.
That's good. Thank you.
Next up, we have Brendan Mahoney presenting stitch granuloma and below the knee amputations with myodesis.
Good afternoon, everybody. My name is Brendan Mahoney. I'm a second-year medical student at Mercer University in Savannah, and I'm presenting a case series today on stitch granuloma and below-the-knee amputations with myodesis. And thank you to the society today for allowing me to speak. Below-the-knee amputations are performed for non-viable, life-threatening limbs in patients with irreversible limb ischemia. Myodesis is one method of performing a below-the-knee amputation. And in myodesis, you attach tendon to bone, and this stabilizes the residual limb. So every time you do an amputation, you basically cut the muscle out, and you're cutting out like an insertion point of that muscle in the body. So by attaching the muscle to the bone, you reinsert that muscle, and that allows for better stability later on. And this is really important for patients that are trying to ambulate later on with just a prosthetic. And so various sutures can be used for myodesis. You can use non-absorbable or absorbable sutures, also braided or non-braided. So just a little bit more on the myodesis procedure itself. You take the gastrocnemius flap and you create the flap with it and smooth out the anterior aspect of the tibia. You also drill 2 holes into the tibia, 2 or 3 holes, depending on the preference of the surgeon. And then you create the myodesis by suturing the Achilles down to the tibia with a crack-out stitch. Again, this can be done with a number of different sutures, but we previously were using non-absorbable braided sutures. And one complication that we had from this was a stitch granuloma. So you see a picture of it here, but basically the body cases off around the stitch and creates an immune response against it. And this has been previously reported in a military population, and you also see it in Achilles tendon repair. So I was working at Savannah Vascular Institute about 3 years ago. I had a clinical externship before I started medical school, and I was trying to learn as much as I could during my time there. So I saw a cluster of patients that had delayed wound healing following amputations, and I was curious of why that was happening. A lot of these patients were diabetic, so they had slow wound healing in the first place. But as we looked closer, we saw that a lot of them were coming and having their stitch, binding the stitch that they used for myodesis later on. So we wanted to determine what the prevalence was of suture granulomas and what we could do about it. So we retroactively looked through our database at all the patients that we had. We looked at specifically diabetic patients who had below-the-knee amputations, and this was from January 2018 until November 2022. This was data from 2 different surgeons at our practice that were performing myodesis regularly at this time. And again, they were both using non-absorbable braided sutures for myodesis. We found 72 total patients in the study, and 25 of them had delayed wound healing that required an additional surgery. Out of those, 6 of the patients had stitch granulomas that tracked to the myodesis stitch. So these are the 2 sutures that we were using at the time. On the left, you see the Ethibond suture, which is used in 56 of the below-knee amputations. And on the right is the fiber wire, which is used in 16. Again, both of them were non-absorbable and braided. And there were 6 patients that presented similarly, but for the brevity of the presentation, I'll just go over one of them. So this particular patient came in November 2021 with diabetic gangrene. He had an immediate ankle disarticulation, and then a couple days later had a below-knee amputation. And we used the myodesis suture for that myodesis. 4-week follow-up, the wound was healing appropriately. Didn't seem to have any complications, and it was healing okay. However, at 2.5 months, there was purulent discharge of a superficial abscess. So previously well-healing wound ended up not healing well, and obviously in this picture. So we had an incision and drainage procedure performed, and we closed the wound by a secondary intention, as seen here. And in the ensuing months, the wound just didn't really ever heal. You see here 5-6 months, still problems with the healing process. And then at 9 months, this problem is still going on. So at this point, we advised the patient to undergo another incision and drainage, which he refused. But at 11 months, he was still having these problems, and he consented to undergo this procedure. During this incision and drainage, we actually tracked it down to the Ethibond suture that we used for myodesis, and we removed it. And after we removed the suture, the healing ensued appropriately after that. So there's months and months of poor wound healing, and then after we removed the stitch, he healed appropriately. And again, this was not just one patient. There were 6 different patients that all presented in a very similar fashion. This is kind of a summary of these patients and how they presented. So the beginning of this, beginning of the green box right here is where each patient had the initial surgery. The end of the green box is when the suture was removed. And within that green box, the patient had poor wound healing, but following removal of the suture, they healed appropriately. And the red line on the side is where we switched over to a different kind of suture. So again, we were having this problem with non-absorbable braided sutures, but then we switched over. One surgeon switched over to zero vicryl and the other to 1 proline, zero vicryl being an absorbable suture and 1 proline being a monofilament. And since making this change, we haven't observed any more suture granulomas. And the importance of this, obviously, we just want to have the best outcome for the patient. So having a delay in the wound process or wound healing process, delays prosthetic fitting, stops the patients from getting back to what they want to do. They can take time off work. That can cause a financial burden on the patient, and then not to mention all the hospitalizations and extra doctor appointments they have to go to. That can take a toll on the patient, and if something as simple as changing the suture that we use can make a difference in that, we want to do all we can to do that. So in conclusion, we have found that non-absorbable braided sutures do have a potential to cause stitch granulomas and below-the-knee amputations with myodesis. We found that since switching to alternative sutures that we have not found any more suture granulomas, and that non-absorbable braided sutures may not be the best choice for below-knee amputations with myodesis in diabetic patients. This adds to existing literature describing stitch granulomas following BKAs, and this is the first case series we're aware of that explores this phenomena in a diabetic population. And that concludes my presentation. Thank you all again for letting me present today, and I'll answer any questions.
Brendan, I want to make sure I understood what you said earlier. By the way, great presentation. Could you expand? This was your idea or something you observed and decided to look into, or something that people talked about? What was your role in this investigative process?
Yeah, so I saw the patients and I didn't really understand what was going on because I hadn't even started medical school yet. But I saw that the patients had slow wound healing, kind of asked the doctors about it. And I mean, I wasn't the one originally that saw the commonality, but they kind of suggested to me hey, this has been happening a lot. Why don't you look into it? And so I started going back through their data, kind of got all the CPT codes from their previous surgeries and looked through all their op notes from the past few years to try to see what the actual incidence rates were. Yeah.
Great job. Thank you.
Our next presentation is Queen Abure. I apologize if I mispronounced that. Medical student, third-year medical student who is eligible for the prize, as Dr. Sherbu wanted me to point out, presenting abdominal aortic aneurysm with horseshoe kidney. Thank you.
Good afternoon, everybody. My name is Queen Abure. I'm a third-year medical student, and I'm going to be talking about horseshoe kidneys with concomitant aortoiliac artery aneurysms. We have no financial disclosures. Now picture this, you're a first-year medical student in your favorite class, embryology, of course, learning about the different congenital renal malformations of the kidney. Most notably, they're probably talking about the horseshoe kidney. This makes sense. The horseshoe kidney is the most common congenital renal malformation occurring in about 1 in 400 live births. It arises during weeks 4 to 6 during the metanephric stage of development and is due to an incomplete fusion of the inferior poles, and the ascent is blocked by the IMA. Now don't worry, I'm not here to make you relive your step 1 days, but why should you care? That was supposed to be up there. Sorry, guys. All right, you should care because what if a patient with an abdominal aortic aneurysm and a horseshoe kidney presents to your office? How should they be treated? Although the co-occurrence of these diseases is exceedingly rare with a prevalence of less than 1%, the anatomical challenges, including the horseshoe kidney placement to the IMA, the isthmus to the aorta, as well as the aberrant renal arteries, proposes a challenge for many modern vascular surgeons. Currently, due to the rarity of this disease, there are no societal guidelines on the best treatment modality. So talking a little bit more about these aberrant renal arteries, type 2 Type 2, there are many different classifications, including the Crawford classification, which looks at the origin of the renal arteries, and the Pampin classification, which looks at the number of different renal arteries. However, the Eisendrath classification, as seen on the screen, is the most commonly used due to having the greatest surgical significance. About 50% of patients fall between type 1 and type 2. Type 2, you have 2 regular renal arteries and 1 axillary artery arising from your aorta to supply the renal isthmus. However, it can get even complicated up to type 5 with arteries arising from your mesenteric arteries, your aorta, as well as your iliac arteries. Now combine this with an aneurysm that has a proximal extent down to your iliac arteries, it can get really difficult when you're trying to find the best treatment modality. So therefore, you have to have thorough preoperative workup with CT, CTA, and a baseline creatinine to determine your best approach. Now, moving on to our case, we had a 59-year-old man who presented to an outside hospital with dizziness, paleness, and near syncope. On workup there, they found an abdominal aortic aneurysm and he was hypertensive. Unfortunately, he left AMA and then he presented to our hospital later on that day due to family recommendation. Upon presentation to AUMC, he was hypertensive with his blood pressure was 194/110. Physical exam showed a pulsatile abdominal mass. There was no notable past medical or surgical history. He did have an extensive smoking history of over 35 pack years, and he had a family history significant for a AAA in his father that never necessitated surgical intervention. Further workup with the CTA, abdomen and pelvis, where the incidental horseshoe kidney was noted. As you can see here, this is our CTA. He had a 6.8 abdominal aortic aneurysm extending down to the bifurcation, as well as a left common iliac artery aneurysm that was fusiform. And you can see his horseshoe kidney coming into place right now. I'll let this play. Notable labs, his baseline creatinine was 0.88 and his GFR was greater than 90. Now moving on, this is also the same image just to show that aberrant renal arteries. And you can see them coming off here, the aorta to supply the horseshoe kidney. Further on, as seen here, his anatomy demonstrated a single right and left renal artery and an axillary artery arising from the aorta to supply the isthmus, which is consistent with the type 2 horseshoe kidney. So given the favorable anatomy and after discussion with the patient of the different treatment modalities, we decided to go with an EVAR with an IBE. Pre-stent placement showed bilateral perfusion of his renal arteries. Here we used a Gore excluder aortoiliac endograft with a left internal iliac component. There were appropriate landing zones. And here's the IBE placement. So completion angiograph demonstrated complete exclusion of the AAA and the CIAA. Bilateral renal arteries remained patent and there was no inclusion of the aberrant isthmic artery. He was discharged home on post-op day 2 with normal renal function and his creatinine remained stable at 0.84. The only complication was a mild type 2 delayed endoleak originating from the lumbar arteries. Unfortunately, he was lost to follow-up despite many efforts to reach out to him. So currently there are many different approaches on how to treat a AAA with a horseshoe kidney. Depending on the patient's presentation and anatomy, you'll decide whether you want to do an open or endovascular. So open, there's 3 things that you want to focus on. If you're going to get good abdominal exposure, if you want to divide the renal isthmus, which has the chance of having a urinary leak of damage to the ureters, and ligation versus salvage of the accessory arteries. The literature says if it's less than 2 millimeters, some even say 3 millimeters, you can go ahead and ligate those arteries. The approaches include midline excision and left retroperitoneal excision. For endovascular, it has the same limitations and approaches for a regular EVAR. You can do a traditional EVAR with IBE, such as what we did, EVAR with hypogastric embolization. You can use a fenestrated endograft as well as the snorkel technique. And as we discussed yesterday, you can even do the hybrid approach. So going into the open cases, it's described in the literature to do the transperitoneal approach if the person is coming in of an urgent setting versus retroperitoneal is fine to do for elective repair. So why did we decide to do an EVAR with an IBE? Endovascular is preferred in all cases, and that's not excluded when you have horseshoe kidney. In the literature, there's about 66 open cases documented in 58 EVAR cases, just due to decreased mortality, short hospital course. However, with EVAR, you need good follow-up, which unfortunately wasn't seen in our patient, which there was no way for us to know beforehand. So between EVAR with an iliac branch endoprosthesis versus hypogastric embolization, the hypogastric embolization has the risk of buttocks claudication, as well as erectile dysfunction or retrograde ejaculation, and even colonic ischemia or perforation has been noted in some cases. So looking forward, horseshoe kidney with a concomitant aortic aneurysm and even more, concomitant CIA is exceedingly rare. We recommend if it's a ruptured aneurysm or type 3 to 4, look at more of the open or hybrid approaches. However, if it's an elective type 1 and 2, even sometimes extending to 3 and 4, EVAR is the best surgical approach. Given the propensity to be prepared, more research is still needed for societal guidelines. Thank you again. Are there any questions? And this is a QR code for the abstract if you would like to read in any more further.
Thank you for that great presentation. I think this will conclude our medical student presentation session. We'll move on to the awards.
I am so impressed by all of them, all of them.
It truly is amazing. I think everybody can hear me, but one of the things please think about supporting the Georgia Vascular Foundation. The medical students get scholarships to come here, and if you've paid for your room at the Ritz, you'll understand how expensive that is. So please do support the foundation. The foundation really tries to support all these medical students to come to this meeting. So I will start an order. Queen, aboard.